Hey, this is Sandy,
And Randy.
and we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. Today we have an education episode.
What are we talking about, Randy?
We were talking about patellofemoral pain.
Oh, very common one.
Yes, very common. It's probably one of the most common knee injuries, I'd say.
I'd agree with you.
Considering that it's just called patellofemoral pain, that's not very descriptive. So the objectives of our episode today are we're going to discuss the anatomy of the patellofemoral joint. I love anatomy.
Of course you do.
Discuss the etiology of patellofemoral pain. We're going to discuss some risk factors, prevention methods, and then areas to address in your rehab.
And action items, which are my favorite.
Oh, you love the action items.
Mm-hmm.
All right, so kicking it off, we got to go basic. Talking about the patella. Makes sense since we're talking about patellofemoral pain syndrome.
Well, I'd hope so. I'd hope you start with that.
So, in general, the patella on the underside of it has very thick articular cartilage that just protects it and the femur. As it glides through the little trochlear groove in the femur. Considering how the anatomy is between the patella and the femur, there's a lot of bony stability. The convex patella fits into a concave femoral trochlea. But what's very interesting when you look at like drawings and diagrams of this joint, the lateral sides are very prominent. So I think that's going to be key later. So keep that one in the old memory bank. Motions of the patella. There are glides, so it can glide superior, inferior, medial, lateral. It'll tilt medial, lateral, and then rotate internally or externally. So there can be a lot of movement there. But
And that's always a good member when you're doing your manual therapy as well.
yeah, absolutely, and your evaluation to see what motions are limited, because there are a lot of soft tissues that keep the patella stable. We're not going to talk about them just because I'll probably start getting boring if we start doing that. So it's probably a good idea I don't. But those motions of the patella, when you're talking about a closed chain, which last time I checked, most athletics tend to be in a closed chain environment. Your foot's probably on the ground.
Would swim be considered open chain? Like if you're...
That's a good question. I feel like it would be, right?
I think so.
Yeah, I think that'd be open chain. Anywho.
But anything that you're running...
Yeah, I would say most athletic endeavors,
basketball, soccer.
Yeah, most athletic things that we would see tend to be closed chain. So what's interesting is the patella is actually relatively stable within the quadriceps tendon. So when your foot's on the ground, it's not really moving too much. But what does move is the femur relative to the stable patella, which is going to be important when we talk about the etiology. Why does this happen?
So why does this happen, Randy?
There we go. Nice segue. So the literature is still pretty unclear why people are having pain in their knee. There's some studies that are looking at its irritation of innervated structures around the capsule, which is kind of a broad statement because there's a lot of structures in the knee capsule, which does make sense. I mean, that could definitely be causing pain and patellofemoral pain. But there's also some MRI studies that have looked at the patella and the actual femur and seen trauma to the cartilage. So those that had trauma just on the medial side of the knee didn't have pain in their knee joint, but those that had pain on the lateral side and medial side had pain consistent with patellofemoral pain. So it's consistent that there's pain on the lateral or damage to the lateral structures.
And what is that likely from? Just mistracking?
So that's what we're going to talk about.
Okay.
That's next. So it's great that what you said, babe, about mistracking. A lot of people would think about, oh, the patella is not tracking correctly. And that's kind of true, except for it's not the patella that's not tracking right, because when we talked about the anatomy of it, it stays pretty stable because of the quadriceps tendon holding it there because of the force. So a key risk factor that's been seen is increased hip adduction and internal rotation during the stance phase of running. So what happens is if you go into excessive adduction or internal rotation, those very prominent lateral structures on the femur get closer to the very prominent structures of the patella, and then they collide. So what happens is there's a lot of force being placed on one area, a very small area, of the patella, and that creates pain because that's a lot of joint forces. Ideally, you would want the patella to sit more even in the femur because then that's a broader area to dissipate forces. Some biomechanics talk right there.
This just reminds me of like when you have a runner and you ask them to see their shoe and you kind of look at like where the wear is. And a lot of times like it might be like on the outside of the shoe or on the inside of the shoe. But, I mean, you can't really do that with a patella, but you can look at different assessment techniques to see like where their hips moving when they're walking or how much abduction or adduction they're getting when they're just standing or moving.
Absolutely. And that I'm glad you brought up the whole like shoe thing because that's true. Like if there's more force and contact area being applied just laterally, that's going to cause a lot of wear, a lot of damage to that cartilage, and hence pain. And plus, the nice thing with identifying hip adduction is it's actually really easy to, one, evaluate it with your eyes, but also like you don't need fancy 3D, imaging techniques or gait analysis to look at this. Even 2D, like even just the camera on your phone has been validated to identify excessive hip adduction. So it's something that we can identify. We may not be able to see too much like excessive internal rotation, but you can probably assume if they have excessive hip adduction, you're probably seeing internal rotation as well. Another thing that's been associated with increased hip adduction is look for if there's a navicular drop or if there's Trendelenburg. Navicular drop itself hasn't indicated to be a risk factor for patellofemoral pain, but it has been when associated with hip adduction.
Interesting.
Yeah.
I mean, I feel like a lot of the times, if you have one, you're going to have to go up the chain, and so you probably have more than just navicular drop.
Absolutely. And the same thing, like look at your Trendelenburg, right? All those factors can contribute to excessive hip adduction.
Mm-hmm.
So the next one, hip strength. Now, I know what you guys think, like, oh, I know this answer. Surprisingly, the evidence does not support hip strength as a predictor of patellofemoral pain.
Interesting.
Right? When I was reading that, I was like, no way, this is false.
So what does it support?
So the reason behind it is because when you think of these studies that look at strength, they look at isometric strength, right? But that does not take into account eccentric strength. It doesn't take into account muscle endurance, and it doesn't take into account neuromuscular control, which I think are very, I don't want to say, well, probably more important than just regular strength because that's how we move. Just because I don't think testing strength in one plane of motion and just like at one angle is going to give you the full story of muscle function. There's a lot more that goes into it. And when you think about running and like doing athletic things, you're not maxing out your strength every time.
No.
And it's funny because I was just talking to one of my biomechanics professors for my class, and we talked about how strength's not a great predictor of these things. We need to look at more neuromuscular issues, like when does these muscles turn on, because they may be strong enough to hold an isometric contraction, but maybe when you're running, they don't turn on at the right time, which if they don't turn on at the right time, you get excessive hip adduction, right? So
then we're just looking at neuromuscular patterns?
Exactly. You should be looking at movement patterns because that is what's going to be more realistic to look at. So even though the literature says hip strength is not a predictor, take it with a grain of salt because I think the hip musculature, which we will talk about, will be very important. But remember, that's what's going to control hip adduction. So even the literature that says, hey, hip strength's not there, remember, they're not looking at different types of strength. They're just looking at isometric strength. So that's a big caveat there. So don't say like, oh, you guys are crazy and you're wrong. Glutes are everything, because I agree, glutes are everything. But you got to change your wording because it might be more of a motor pattern thing instead of a true strength thing. I hope that all makes sense.
Basically, you are not testing someone in one moment of time. You want to look at their strength over time.
Yes, thank you. Or just how they control their limb, their timing, and all that. See, I'm glad you're here because you keep it real for everybody.
I know how it is listening to podcasts.
So the last one that I looked at, and there's many more that I've looked at the literature, but these are kind of the more stronger ones, or at least most common that people would think about, quadricep strength. So they have found that weakness in the quads is a risk factor for developing patellofemoral pain.
Now, is this weakness at one moment in time, or?
This one would be an isometric contraction kind of thing. And the whole idea is if your quads are weak, the forces aren't being absorbed by those active tissues and the tendon, but they have to go somewhere else, which means they're going into the joint. The joint's having to absorb those forces. That causes pain, that causes degeneration and all that. So that's the idea there. And it does make sense as far as, most people try to think like quad dominant's bad. And that's true, being quad dominant's bad, but you do need the quads. Let's not feel like they can be neglected. So keep that in mind, that patellofemoral pain, a risk factor. If you're seeing someone with quad weakness, you're going to want to increase that strength.
But then again, I do want to point out, like, even what was it yesterday in our workout, that I'm pretty quad dominant. So I was like, okay, let's do some glutes first. And so I like completely fatigued out my glutes. And then near the end of the workout, my quads hurt so bad and I couldn't complete some of my quad exercises. And so I was talking to Randy about this and I was like, man, like I literally cannot get through some of these things that I'm doing. And we determined that it was probably because I had done glutes first. The reason why I had done glutes first was because we wanted to get that activated, but I probably should not have gone to fatigue. Instead, we want to get that glute activation, so that glute and hamstring activation, and then proceed into the quad exercises, not completely fatigue and then have the only option have the quads up there.
And hence, going back to the hip strength thing, they didn't take into account endurance.
Yep.
Because that can make a big deal.
Mm-hmm.
So,
and that was only a 45-minute workout.
Yeah.
Imagine if I was a soccer player and I was doing a longer practice.
Yeah, exactly. I mean, a game is 90 minutes. So we talked about the risk factors. What comes next?
How to prevent stuff.
How to prevent stuff. That's right. I love it. So the biggest thing is you're going to, like we talked about, focus on neuromuscular control and then add in the strengthening as well. So you want to increase your hip control. So by controlling the hip, strengthening glute max, glute med, glute min, external rotators, all that fun stuff, it's going to help control that excessive hip adduction and internal rotation.
So if it's attached to the hip, strengthen it.
Strengthen it, baby. It's also going to stabilize the pelvis. We talked about Trendelenburg can cause poor movement patterns. So like I said, glute med, strengthening the core. That's good.
I was going to say, you know what else attaches the pelvis?
Yeah, absolutely.
The core.
Absolutely. You do definitely want to work on core. One, it stabilizes the pelvis. And two, I'm pretty sure I've said it before, but there's been studies that have shown that proper core activation leads to better activation of the lower extremity muscles.
And we're not just talking rectus abdominis. We're talking obliques. We're talking erectors.
QL,
yeah.
I mean, again, most people view the erectors as, they're always overactive. They're terrible. Well, don't neglect them, though, because some people may need those to be activated more.
Mm-hmm.
Next, after you get that all taken care of, if someone needs it, do quad strengthening. It's very important. It's been shown to be a risk factor. But remember, you can do this functionally. You don't have to throw someone on a knee extension machine and call it a day.
Or on wall sits.
Or on wall sits, yeah. Think about it. Squats do both quad and glute.
Split squats, regular squats.
Absolutely. So you're still working on glute, which we've said multiple times, probably beating a dead horse at this point.
But don't beat them up so bad that your quads take over.
Exactly.
Learn that from me.
Exactly. So if you do exercises that are more functional, like squats, split squats, lunges, anything like that, you're still going to strengthen quads, but you're also getting the glute activation as well, which I think is better than just go on the knee extension machine and do that. And I think that fact that you should strengthen the quads highlights how important it is to have a good strength and conditioning staff. I feel like sometimes they get overlooked as far as injury prevention. And obviously they're great for getting those performance gains, but they're key to injury prevention because everything they do in the weight room is strengthening. It's getting them to move better. So much respect to our strength and conditioning listeners.
Now, if you are someone who has strength and conditioning coaches at your place of employment, then totally go in and talk to them and make sure that what you're doing and what they're doing match up. Because the worst thing in the world is that one of you guys is working on quads and one of you guys is working on something else, or you're both overloading the quads maybe, and then that's maybe why you're not seeing the gains that you should be.
Yeah, that's true. That's very important. Communication is key.
Mm-hmm. That's a huge part of our podcast. If you guys have been longtime listeners, I think that's a key for us.
I do have to say, talking to the strength and conditioning staff, I've loved it. Some of the most intellectual and thought-provoking conversations have come from them.
I've never worked at anywhere that's had strength and conditioning staff.
It is awesome. They are a great group of professionals, and I do emphasize professionals.
That's awesome.
And then, of course, we can't talk about neuromuscular control and strengthening without talking about movement patterns. The biggest thing is we need to teach these athletes how to move. Even though we're doing strengthening stuff, that doesn't mean they're moving better. And a big highlight to this is one study. They took a group of athletes, did a single leg squat assessment, found that, oh, you moved terribly. Did glute strengthening, and they found no changes in their single leg squat performance. And the idea is, even though you've done strengthening, you're not doing neuromuscular control. You're not teaching them how to move. So if you see someone who has excessive hip adduction when they do a single leg squat or while they're running, you need to teach them how not to do that. And that goes back to motor learning, teaching them how, like, oh, my biggest thing is when I have someone, like, I pull a band on their knee to do a valgus collapse, and I tell them, like, hey, don't let the band beat you, right?
Mm-hmm.
So now they're thinking, like, oh, I need to resist the band. Well, to resist the band, you do some external rotation, hip adduction, and then the idea is they're learning from that.
That's awesome. I like that one too.
So, as Sandra has said before, we would like to prevent all injuries.
Have I said that before?
Yes.
No, because that's...
I'm pretty sure in our Achilles one...
Whoa. Job security, man.
Hey, but if we're preventing them, we're still working.
That's true. Actually, one of my jobs is like 90% injury prevention, so you're right.
So, what do we do when we get that injury?
You rehab and treat.
Yes. So, you're going to do the same thing basically as what you would do for your injury prevention. You're going to strengthen the hips. And this is where people started thinking that, oh, hip weakness causes patellofemoral pain, because the retrospective studies that they were doing took people with patellofemoral pain, tested their hip strength, and they're like, hey, you have weakness. Maybe that's why you are getting patellofemoral pain. Obviously, through prospective studies, we know that's not exactly what's happening, but that information from those retrospective studies are still very important. It gives us an indication of what we need to treat when we have someone with this pain. So if someone comes in with patellofemoral pain and they've had the pain for a while, you can assume they have weak glutes. We need to work on those. So that's one benefit of retrospective studies. I know a lot of people like to knock them, but there are benefits because it does help guide your rehab when you do have someone in pain. Plus, the studies that have done treatments and rehabs and compared them to controls and all that have found that if you combined your rehab with glute strengthening and quadricep strengthening, there are actually better outcomes for the patient than just quadriceps training or like just knee strengthening exercises. So that just shows how important the glutes are to this, that you can actually get a better outcome.
Now, really fast before you keep going, for our new listeners, I just want to point out something that we like to highlight pretty much every episode is that this research and everything that we read, or everything actually that Randy reads.
No, she says it. We read.
You got to remember that nothing is ever going to be 100% or unanimous. So if they're saying that, some studies are showing that patellofemoral pain was present with glute weakness, that's going to be most people. Remember, so you might have some patients who do not have this weakness or do not have, whatever the majority of the finding is. So you have to really make each decision very individualized.
Absolutely. You should treat the person, not the injury.
Exactly.
And if we're strengthening hips, we're probably strengthening the core. And in the same idea as when we talked about injury prevention, we're trying to control the pelvis. If you're, I like to think of the pelvis as a punch bowl. If your punch bowl's dancing all over the place, spilling juice, it's not going to be, an effective base for your lower extremity muscles, and it will put joints in a bad position.
And I mean, Randy and I were just talking about this. Sorry you guys weren't there, but I'll clue you in. So basically, we were talking about when you are training the core, we really need to be making sure that the core is a stable environment. And so when you're training the core, you should be incorporating upper and lower extremity movements, because that's really what's going to be happening in real life. When you're walking up the stairs, guess what? Your core should be stable so that it's protecting your back and you can lift those legs to get up the stairs. Same thing as if like you're swinging a bat. You want to make sure that you're protecting your back with that core as you use that, make that rotation.
Absolutely. It goes back to those studies on low back pain, that those with low back pain tended to activate their transverse abdominis way later, or at least weaker, when they just did the simple task of lifting up their arm. Like, that's a big deal. That just shows how important this core musculature is to movement in general.
And not necessarily saying that it's weak, but sometimes it's just a faulty movement pattern.
Yeah, exactly.
So sometimes it just needs to be retrained.
Exactly. Like we were just saying, that if it turns on late, well, it could be really strong. It just doesn't activate when it should. That's a big deal.
Mm-hmm.
Another thing that you should look at when you're strengthening these, or when you're rehabbing these athletes, is to actually strengthen the quads. Now, we're not saying, hey, your patellofemoral pain kid comes in, day one of his rehab, he's in pain. All right, we're going to hit him with some squats. No, we're not saying that, because it's probably going to hurt, right? And the NATA actually put out a position statement on patellofemoral pain, I think a couple years ago. And I was just, going through it. And there was a really lot of good information. Like, they were saying that your rehab program should start with 3 weeks of isolated glute strengthening before you do any quad strengthening. And I think that's a great idea, because you're focused on getting the glutes to fire. You're letting the knee pain kind of go down, let the tissue heal, let their pain decrease. And then once you have a good base with your glutes, then start working on quad strengthening. So now you're putting them in a better position to work on quad strength, because if we know anything about knee pain, if you have knee pain or swelling, what do the quads like to do?
Turn off.
They like to turn off. That's not a good idea when their pain's gone and they get back out there and quad's not working correctly. So obviously we still want to strengthen quads, but keep that in mind. Glute strength should come first, and then you start working on the quads once their pain starts going down.
What are some of your favorite things to do, like tape or bracing wise, for patellofemoral pain?
I haven't dove into a ton of the literature on taping and like bracing and stuff. There is still good evidence for different tape applications, like KT tape. I found a lot of success with doing KT tape with a lot of my athletes, because it's not bulky, and they like it.
What's the point of the KT tape for the patellofemoral pain?
Basically, anytime you try to do KT tape for pain relief, you're basically adding tension to the tape. The tape lays down and it pulls on the skin. As we go back to our, our modalities class, I know everyone loves modalities, you're essentially trying to use the gate control theory. You're activating the mechanoreceptors in the skin to stimulate those inner neurons that turn off the pain signal, or at least decrease the pain signal.
So you're talking mostly about pain relief.
Exactly.
Okay.
And then there is some success with the McConnell tape applications. I've done McConnell a few times for some athletes who didn't respond to KT tape, and they loved the McConnell tape.
Mm-hmm.
And it does have some anatomical basis, right? You're pulling the patella medially, so it's out of the way of the femur. So it makes sense, and it can definitely work. So I wouldn't say don't do it. It's definitely an option.
You know what that reminds me of? It's kind of like, it's a great Band-Aid for, you're still in pain, we're working on it, but the more you do this movement, the more you're just going to keep pressing that spot that hurts. So why don't we just take that patella and move it off the spot that hurts, so that we're not continuing to press that pain button?
Exactly. Let's give some room for the femur while we're working on it.
Yeah, because I remember one time when I was rehearsing, you had to do that for me, because it was like, I'm going to continue doing all these jumps.
Well, you had no choice. You had a show.
Yeah, and I was going to continue doing all these jumps, and there's no time for me to go and fix the problem. So right now, taping's what I need.
Yep, exactly. It can be useful.
Mm-hmm.
So I would say the last thing to focus on, but not as important as the rest, still very important, is retrain those movement patterns. If you're seeing someone run terribly and it looks like they're a weird looking duck while they're running, it may be a good idea to start doing some gait retraining, or teaching them not to do excessive hip adduction when they move, when they squat, or those knees caving in. Let's work on that. Let's teach them how to move properly. And I think that's one of the most important things to work on. Like, yes, we need to work on activating our glutes, and they need to know what it feels like. And we need, if there is true weakness or if there's true activation problems, let's focus on them. But at the end of the day, your rehab shouldn't stop there. It should then be teaching them how to move better.
But I will also add, I have had an athlete who literally his nickname was Crazy Legs because
Why was his nickname Crazy Legs?
he looked like he was going to tear an ACL every time he ran. And I'm not kidding. So but I will say it was one of those ones that we didn't touch his movement patterns at all because what he was doing is working for him. And honestly, he was very, very anti-injury prone. So it's like, don't fix what's not broken.
That's true. That's something to be taken into consideration as well. So I think that's it. That's all I got. Those are all the knee slappers I got today.
That was a good one. So you guys, this was an awesome episode. Thank you, Randy. If you want to comment on this episode, podcasts are so great, but you can't comment on them. However, we do have a Facebook community where we do post episode threads for each episode, even our story episodes, which we'll get into in a second. So if you guys want to join the AT Corner community, you totally can. It's on Facebook. So it's facebook.com/group/ATcornerpodcast. There's only one membership question to get in, and it is, where did you hear about our podcast?
That seems easy enough.
It does. I hope so. So anyway, we do every other episode as education or stories. So you guys just heard an education episode. The next episode is your stories from real athletic trainers practicing in various settings. And, we talk about, sometimes we had, what was our last one? We were talking about AT Heroes.
AT Heroes, that's right.
Mm-hmm. Our next one is going to be favorite gifts or ways that we've been thanked as athletic trainers. I think it'll be perfect to wrap up December.
I think so too. I mean, it is December.
So we do have some upcoming story episodes that we'll be posting on our Instagram stories. So if you want to submit your stories to be in some of our future episodes, you totally can. Head over to our Instagram or email us at atcorners@gmail.com. And then don't forget to share, rate, and review. We really appreciate you guys' feedback. We've gotten some great feedback from you guys. We love doing it for you guys. And selfishly, we love sharing and having this platform for ourselves.
Absolutely.
And our community is so, so great. We're having so much fun with it.
Also, with this being December, that means everyone's finally ready for 2020 to be over.
Yes, let's get rid of this year.
And with 2020 being over, that means 2021 starting. You know what 2021 is?
No.
2021 is a reporting year for the BOC.
It is. You're right.
That's right. So it's time to get those CEUs ready. And what better way to get CEUs ready than utilizing the services of MedBridge?
If you guys haven't heard of MedBridge, it is super awesome. Randy started using it, a year or two ago?
Yeah, about a year ago.
And basically what it is, it's online. It's kind of like what we're doing, except you can actually get CEUs for it.
And they go definitely a lot more in depth, and a lot of experts are actually on there just presenting topics. It's really cool.
Yeah, so CEUs on your own time. And we actually do have a promo code. MedBridge reached out to us, which is so awesome. We have an affiliate link. So if you guys want to get $175 off.
Whoa, that's pretty good.
I know, it's a really good deal. So you can use the code ATCorner at checkout, and we have it in our show notes below as well.
Absolutely.
You got anything else to add, Randy?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.